Hello, I'm Dr. Seeman Chaturvedi. I'm the Stuart Greenbaum Endowed Professor of Stroke Neurology at the University of Maryland Medical System. I'm a vascular neurologist and I'm the system-wide director of stroke in the University of Maryland Medical System.
Hello, I'm Dr. Payal Kohli. I'm a non-invasive and preventive cardiologist based in Denver, Colorado. I own and run my own private practice. I'm also an associate adjunct professor of cardiology at both Duke University and Johns Hopkins University.
Hello, my name is Fatima Rodriguez. I'm an associate professor of medicine and lead the section of preventive cardiology at Stanford University. Premature CVD is when events such as heart attacks, strokes, or peripheral arterial disease occurs sooner than is expected based on general population estimates. So in general, in the United States, premature heart disease is under the age of 55 for men and under the age of 65 for women, because women generally tend to have heart disease at older ages.
But here in 2025, we actually need to think beyond that definition, because it's not just what age you get disease, but if you're getting disease that's more aggressive for your age, for example, you're in your 30s or 40s and you already have plaque, to me that's a marker of more aggressive atherosclerosis, and that really defines premature cardiovascular disease beyond just the age cutoffs that we've used in the past.
Lipoprotein A can drive premature ASCVD in 3 ways. So it is similar to the LDL particle, but has an additional apolipoprotein A component to it that can directly penetrate the arterial wall and create the process of plaque formation. Second, lipoprotein A, one of its hallmark features is that it's very similar to plasminogen, so it inhibits the degradation of clots, so therefore it's really prothrombotic. And finally, lipoprotein A is a pro-inflammatory molecule. It carries oxidized phospholipids, and that in itself can lead to endothelial dysfunction and platelet aggregation. There is a strong association between elevated levels of lipoprotein A and premature atherosclerotic cardiovascular disease, and this has been demonstrated in several lines of data. The first is very strong genetic data from Mendelian randomization studies, where certain genetic variants that are associated with elevated lipoprotein A levels also are associated with a much higher risk of premature cardiovascular events, and this really proves the causal relationship between elevated lipoprotein A and cardiovascular events. Second, there's a lot of really strong observational studies from prospective cohort studies that again show that if you follow individuals with elevated lipoprotein A, they tend to have much higher rates of premature events, between 2 to 2.5 times higher than the general population.
Elevated LPA is quite common in individuals with premature cardiovascular disease. We know overall in the general population, about 1 out of 5 individuals may have elevated LPA levels. If you take the patients with premature cardiovascular disease, it increases in frequency to 1 in 3. And as a vascular neurologist, I can cite one example of a patient who had a stroke in his early 50s, and he had severe carotid artery stenosis, ultimately requiring carotid surgery. And when I tested his LPA LPA level was between 250 to 300 nanomoles per liter, which is several times higher than the upper limit of normal. And this is very important because there are a large and increasing population of individuals who have ischemic stroke or myocardial infarction at younger ages. And this has great economic and personal significance to these patients. You can imagine that if you suffer an event like an ischemic stroke at age 45 or 50, the profound economic and financial implications it has for the patient and their family. Because if it's a disabling stroke, they may not be able to work, they may have multiple visits to the hospital or to healthcare providers, and they may require readmission for other vascular events. And so therefore, we want to do everything we can to identify individuals who have elevated risk and institute a global cardiovascular risk reduction strategy. Studies have shown that individuals of African or African American descent have the highest levels of LPA, and then there are other groups which are intermediate levels in terms of their frequency of having elevated LPA, and that includes Latinos, South Asians, and those of Middle Eastern descent.
And in fact, what we see is that out of patients who have cardiovascular disease, up to half of them that are Black can have elevated lipoproteinase. And then if you look in the Hispanic population, 1 out of 4 of them can have elevated lipoproteinase. And we see similar numbers in the South Asian populations.
It is absolutely critical to remember that there's significant heterogeneity within populations, and that difference is often more pronounced than that between populations. For example, among Hispanic individuals, we know that certain populations that have more African ancestry, like Dominican individuals or Puerto Rican individuals, have higher lipoprotein levels than those with more Amerindian ancestry, like Mexican Americans.
If patients have cardiovascular risk factors or have had an ischemic event at a relatively young age, it becomes extra important to test for elevated LPA in these ethnic groups. LPA levels are measured with a widely available blood test, and that's become increasingly common and increasingly standardized in the last decade, and so it should be widely available for clinicians.
So there's some variability in guidelines around lipoprotein A testing across practice guidelines. Some guidelines, for example, in the preventive cardiology space, recommend universal testing once after early adulthood. This is a genetic risk factor and it's really not modifiable over time. But most practice guidelines agree that individuals that have a family history of early heart disease, individuals with premature heart disease, or even those with existing atherosclerotic cardiovascular disease who have recurrent events despite optimal therapy, these are all individuals that should absolutely be tested for lipoprotein A.
You know, even though the expert consensus documents and the guidelines tell us to check lipoprotein A in patients with premature disease, or perhaps even everyone, we are not checking it enough. If you don't check, you don't know what's happening. You don't know that this marker of risk is elevated. You certainly can't do anything about modifying that risk. So it's a huge miss from a medical perspective, and we need to do better with getting those rates up. Now we're doing better overall. We've started checking it a lot more than we used to, but we can do so much better. We really need to get those numbers up because the value that a lipoprotein A adds to understanding the patient's risk, to helping to educate them, and to be thinking about changing their medical therapies based on this elevated marker of risk is really so important. So we need to increase that number. In my mind, as a preventive cardiologist, no cardiovascular risk assessment is complete without incorporating lipoprotein A because it is such a strong predictor of cardiovascular events. And in fact, the assessments that we have that don't incorporate lipoprotein A, in my mind, are somewhat incomplete. So I use the lipoprotein A being elevated as a risk reclassifier, as a risk modifier. So I bump the patient up into a higher risk category so that I can be more aggressive with their other cardiovascular risk factors.
In terms of management for individuals who have elevated LPA, at the current time there are no approved medications which specifically target the LPA.
People often ask me, well, why should I check a lipoprotein A? Because there's nothing I can do about it. There's not therapies out there to really reduce it. And I say there's many things you can do about it today in 2025. I'm more aggressive with many of the other risk-reducing therapies, such as their weight and their blood sugar and all the other medications that I have in my armamentarium.
I always tell my patients genetics is not destiny, but it is extremely helpful to know if you're increased genetic risk for premature heart disease. I would say that for me, this allows for a better shared decision making around preventive strategies, motivates patients to adhere to therapies for modifiable cardiovascular risk factors, and particularly around lifestyle. Patients tend to exercise more, eat better when they know that their genetics are against them, but they can do something about it.
So to me, having an elevated lipoprotein A really helps me to better understand the patient's risk and really put them within context of how I can reduce their risk.